Some people are still questioning the subfascial breast augmentation plane. Tell me your take or your thoughts on this operative plane.
Well, I wish they wouldn't, sort of argue that there's no subfascial plane, because there actually is the subfascial plane. What I think the point is that sometimes it's very well defined in some patients, and you'll have those patients occasionally where the fascia is very thin, and it seems as though you're not really doing anything important by going subfascial. The pocket is so easy to dissect subglandulally because you have that pocket right over the top of the pectoralis fascia. That being said, I show pictures, and I have some new chapters coming out, like in operative techniques, where I really show the fascia like flying in the air, where I've actually looked at the fascia, and it's actually a layer present. So if you're dissecting your pocket and you see the glistening muscle belly, you're really in a subfascial pocket. And the two places I think it matters is medially. If you're under the fascia, it really controls your medial dissection because it attaches as it hits the sternum. Right. And it can, because one of the problems with being subglandular is that you inadvertently go too far and you can increase the risk of symastia and some of those issues. So I think medially it's really nice to be at that level of fascia because it sort of stops you as you get to the medial edge. And then superiorly, especially when you have shaped devices, that when you have a loose breast and you're subglandular, often the upper pole in a very short period of time is no longer controlled, and you can get rotation of the shaped device. But if you're in the subfascial pocket, you get a sort of stability that's created by that fascia that helps to stabilize. You can make an exact pocket where you're dissecting in that subfascial plane, and you're creating that hand and glove fit that's really hard to do in the subglandular pocket. You do it, but the tissue's stretching and it's not holding that pocket. So definitely in shape devices to prevent upper pole rotation and in sort of controlling the medial pocket with symastia, I think there really is some benefit to subfascial. But in those patients who don't have strong fascia or who are using just a simple round device, then probably the efforts at making a subfascial pocket aren't worth it. What I say in one of my chapters is that when I have somebody with 2 centimeters of pinch test in the upper pole, I like to put them subfascial because I'm on the border of what I think is acceptable for a subglandular subfascial pocket. Once they're at 3 centimeters, I don't think they hold any benefit. There's plenty of upper pole tissue, and you can go subglandular. So I'm in 2 to 3 centimeters, I tend to be more subfascial. And beyond 3 centimeters, I may tend to be more subglandular with that. Of course, if somebody's less than 2 centimeters, then I'm doing some form of a dual plane submuscular pocket.
Awesome. Well, thank you very much for that insight. We'll look forward to seeing your chapter. Dr. Calobrace, can you talk to us briefly? Do you feel there's a role for pharmacologic prophylaxis in preventing capsular contracture?
I think that there is. I think that there's some data that supports it. I think Ruth Graf came out with some stuff, some reports on that. And I know certain people like Dennis Hammond even is more routinely giving some prophylaxis with leukotriene inhibitors post-surgery. He thinks that may be very helpful. I have used it in patients I feel are at risk of capsular contracture, meaning they've had a capsular contracture in the past. And so I'll use it for a 3-month post-operative course. And definitely when I start to see the early signs of a capsular contracture, I think there's real benefit. And I've seen many a patient who break the cycle of a worsening capsular contracture and increasing grades of capsular contracture with the use of the anti-inflammatories. What I've tended to use, which is vitamin E, which has very weak data on it, but I think many of us use it as an antioxidant in a way, along with a leukotriene inhibitor, which I think most of us use singular now because some of the toxicities associated with accolate.
Right.
And then there's even some small amount of data that may be using even some antibiotics. So we use some minocycline for a 3-month course as a low suppressive dose. And there's been some data supporting that, or some sort of other anti-inflammatory like ibuprofen. Everybody has their own idea, but something to break the inflammatory cycle with that. The other thing that we have in our practice that not everybody has is something called an aspen. And an aspen is a very large breast ultrasound that is used to help treat capsular contractures or early tight myofascial tightness that creates an implant that's not falling like you would like it to. And we actually use that device along with antibiotics, and it can show there's really good data to support a breaking of that capsular contracture with the use of ultrasound combined with antibiotic protocol, there's some sense that maybe the ultrasound helps the antibiotics to penetrate through the biofilm, because the biofilm is so resistant to the antibiotics getting into it, and that becomes the real challenge with trying to deal with anything that's biofilm associated. So most of the time we've just been trying to deal with the anti-inflammatory piece of it. So I think all of those, some ultrasound mixed with some anti-inflammatory management, maybe antibiotics may be beneficial. I think it's worth trying. I think most people that do a lot of breast surgery all use it really because they have a significant amount of benefit with very little morbidity associated with those medications.
Very nice. Well, that's good. That's nice to know, and a nice tidbit about the ultrasound as well. Thank you.
Okay.
What are your thoughts on composite augmentation? In other words, breast augmentation combined with simultaneous fat grafting.
Yeah, I think composite augmentation with fat grafting and an implant is where fat grafting makes a lot of sense, and maybe not routinely in my practice, but in specific situations, when somebody has asymmetry, sometimes we try to use two different types of implants or sizes of implants, and maybe the better way to do it is they have two different sized breasts in essence, is equalize the breast volumes with fat grafting and then put two of the same size implants in general. People that have chest wall asymmetries or upper pole chest wall depressions, you don't want to put a big implant in that's going to reach all the way up to the upper pole. You can use fat grafting, like in a patient with pectus excavatum, to create symmetry for those patients. In constricted breast deformity, where they actually lack volume coverage sometimes after releasing it in the lower pole for getting expansion, you can use fat grafting to sort of expand out that lower pole while you're doing it, which can be nice. Or also somebody who doesn't want to be over-augmented but wants good cleavage, you can use a smaller implant to give them core volume and projection, and then use fat grafting in the cleavage region in order to do a better job of creating softness in the cleavage area without using a larger implant to reach across. Those are just a few examples of where I think fat grafting as a composite with an implant can be very beneficial. Fat grafting by itself as a method for breast augmentation, in most of the United States surgeons' hands has been, sort of lackluster in a way. I think maybe because what our patients want is a core volume that's larger than what fat grafting can usually provide. And that's quite different than what we find in Europe, where they use much smaller implants, and maybe in South America, they use smaller implants, and they may be able to achieve the aesthetic goals of their patients with going up just 1 cup size with some fat grafting for that. Also the use of like the Brava bra, which was very helpful and beneficial in creating some induction of the breast tissue to help get a better take of fat grafting and really be able to put more volume in at one time. That the Brava is not available really right now, so we've lost some of that ability. But for composite grafting in reconstructive breast surgery, I think fat grafting along with core volumes with implants is really where the place is for us, and I think that's going to be the sine qua non for in the future, how we just really become masters of breast surgery.
Excellent. Thank you. What about operating on factor V Leiden patients? That was brought up in this article. I just wanted to kind of get your thoughts on that.
Yeah, so there's a lot of thrombophilias that we run into in practice with my patients. Of course, when I'm doing something that's longer, a longer operation or a higher risk of blood clots like an abdominoplasty, I become much more concerned about any thrombophilia. As it relates to factor V Leiden, or they call it FVL, it is it's usually heterozygous, and there's really no benefit to doing any sort of chemoprophylaxis for those patients. Although what's weird is in many of the studies, when they looked at it, they saw no increased risk of venous thrombosis, but at the same time, all the patients had been prophylaxed in some way, right, had antithrombotic therapy. So it was hard to assess it, but just saying with some general rules of antithrombotic therapy, there's no other reason for concern. So I think in non-cardiac surgery, especially even in orthopedic procedures, there's no need to screen for it. And there's no reason not to do, especially straightforward breast surgery with that, and just use your typical antithrombotic therapy. We'd use basically sequential compression devices or something like that, unless they have some other risk factors associated with it. But I'm never against being thoughtful and thinking about what some of those risks are when we hear about patients who've had miscarriages or had a history of having a blood clot or some family history of blood clot, that maybe before we step into any operation, we actually do a thrombophilia workup and make sure that we know what the risks are going into it. Because I promise you, I've had patients get DVTs and even PEs with operations that last less than an hour. I did upper lower bluffs on a lady, and her surgery was 1 hour and 5 minutes, and she got pulmonary embolus from it. So, and she had a thrombophilia, as it turned out. And so they're lurking out there in a way, and we don't want to hurt them. So when we ever elicit a history that makes us concerned, then I think it's reasonable to step back, do a thorough workup, and make sure. But as far as factor V Leiden, I think people can go ahead and proceed with surgery.
Excellent. Thank you very much.